Okay, time to do some business. So we are starting today with influenza and Dr. Walter.
So I'm introducing the influenza immunization or influenza session today. This is, I think, the first time I've had the first session of the morning. So these are members of our work group, including the ACIP members, ex officio members, consultants, and liaison representatives. As you would see, I think we probably have the record for the largest work group. So I'm just going to briefly recap our last session in February. At that meeting, we had a presentation from GlaxoSmithKline of the results of a randomized controlled trial of Fluarix quadrivalent for children 6 through 35 months of age. And as many of you all know, that vaccine is now approved down to for children 6 through 35 months of age and upward. We also heard a presentation at the last meeting following or during the midst of heavy influenza season about the U.S. influenza surveillance and vaccine effectiveness updates. And then lastly, I don't think many of us will forget, we had presentations on LAIV. We had a presentation from MedImmune of a study shedding and immunogenicity of quadrivalent LAIV containing the new pandemic H1N1-like virus. That was followed by Lisa Grosskopf's presentation of combined U.S. individual patient-level analysis and systematic review of LAIV effectiveness, and that culminated in a vote for the recommendation of use of LAIV for the 2018 and 19 season. So if you all think we went home and didn't do anything after the last meeting, we've actually been fairly busy. We have calls every 2 weeks, and during those calls, we've accomplished quite a bit. We previewed and discussed the current presentations today that you'll hear about U.S. vaccine effectiveness estimates from the CDC, and that includes data from the U.S. Flu VE network and also the Haven network as well. Then we had a presentation, which you'll hear about today as well, looking at the FDA study of relative effectiveness of cell culture-based versus egg-based vaccine, I think a topic that many of us are clearly interested in. Then that was followed by the 2017-2018 influenza vaccine safety surveillance update. And then we heard a presentation previewed to the work group from Securis about a study of quadrivalent adjuvanted inactivated flu vaccine for young children. We have spent a lot of time, and Lisa has done quite a bit of heavy lifting, reviewing and drafting the ACIP recommendations document for the coming season, which will be discussed. In addition, we had the formation of an influenza sub-working group. This group was formed with the purpose of providing advice on a study of spontaneous abortions following IIV. And we met for the first time in April, and we reviewed the protocol for the VSD SAB study and provided recommendations for both secondary analysis and sensitivity analysis. And this work group, sub-working group, is ongoing. So for today, these are the presentations. We have a rather packed agenda, which I think lasts for a little bit. We have a vaccine effectiveness update. You'll be hearing data from the U.S. Flu VE network and Haven. That'll be presented by Dr. Flannery. Then we'll have a presentation of the relative effectiveness of cell culture versus egg-based influenza vaccines in the 2017-2018 season, and that'll be presented by Dr. Liu. And I think this is really a preview of looking at effectiveness of individual flu vaccines that we'll be looking at towards in the future. We then will be looking at the influenza end of season update with the vaccine safety monitoring. That'll be presented by the Immunization Safety Office and Dr. Shimabukuro. He will be up here for a while because he will then present some data from the SOMNIA study, which is looking at narcolepsy following adjuvanted monovalent pandemic H1N1 flu vaccine. That'll be followed by a presentation from Securis by Dr. Sylvester looking at the adjuvanted quadrivalent influenza vaccine, which is now approved for older adults, but this is a study looking in young children. And then finally, Dr. Grosskopf will come up and present the work group considerations for the 2018-19 recommendations, and that'll be followed by a vote for these recommendations, which really don't represent any significant changes. So with that, I'm going to turn the presentation over to Dr. Flannery.
Great. Good morning. So the real work on the U.S. Flu VE network data analysis was done by Jesse Chung in our influenza division. The acknowledgments for the U.S. Flu VE network and the extensive list of people who contribute is at the end of your slides. And for the Haven network, Jill Ferdinands and Elif Alinak for those numbers. And again, the acknowledgments for the Haven network are at the end of the slides. So I'm going to go through quickly the preliminary estimates for this season. We do not have a surveillance presentation as we did in February, but this headline from the New York Times pretty much sums up what the message was at the February ACIP meeting in terms of the severity of the flu season. CDC tracks severity now in several different indicators, including influenza illness, hospitalizations, and deaths. The composite indicators are shown here by age group, children in light blue, adults, and older adults in darker shades. All age groups is the first column, which is a little bit difficult to see on the slide. The severity for this composite indicator is organized into 4 categories, from low severity to very high severity. The 9-10 season reached very high severity for the indicator in children, but other than that, there have been several seasons since the 2009 pandemic that have reached high severity for this composite indicator, and 2017-18 reached high severity for this composite indicator for all of the age groups and for all age groups together. Now I'm going to go through the preliminary estimates for the 17-18 season for the U.S. Flu VE network. There are 5 collaborating institutions shown here with the principal investigators for each of these collaborating sites. The methods are shown here just to highlight a couple. These are outpatients 6 months and older with acute respiratory illness and cough less than 7 days duration. Notably, this is not an influenza-like illness definition with fever, and it's slightly more sensitive for any flu illness. The dates of enrollment for the U.S. Flu VE network are during periods when influenza circulates at the sites and ranged from November 2nd to April 20th, varying slightly by site. We use a test-negative design. All patients are enrolled and tested for influenza by the RT-PCR assay. We compare the odds of vaccination among the PCR-positive cases to the PCR-negative controls. That gives us an odds ratio that's used to calculate vaccine effectiveness as shown below. Notably, the vaccination status for this analysis is not our usual vaccination status final season definition. This is still like our interim estimate, at least 1 dose of 17-18 seasonal flu vaccine according to medical records and immunization registries at most of the sites, and then at some sites includes self-report. The adjustments are made for several of the variables shown at the bottom of the slide. The pie graph on the bottom of this chart shows the distribution of the flu positives. We had almost 9,000 enrolled, 8,900 enrolled, and 8,635 are included in this analysis. 36% of those enrolled were flu positive, and the main predominant influenza virus was H3N2. Among bees, we had B. Yamagata as the primary lineage. There was very little B. Victoria, and notably there was enough H1N1 to have estimates for H1N1 vaccine effectiveness, which is notable this season because this is the first season with the A. Michigan AH1N1 strain. It is not as relevant for this presentation, but the B. Victoria lineage was the trivalent vaccine lineage for this season. This curve shows the enrollment by week. The gray bars show the flu negatives, and the gold bars show the flu positives. You'll note that during the middle part of the season, essentially from weeks 1 until weeks 9, there was a very large number of flu positives that were enrolled. The percentage of all those enrolled who were positive is shown in the dark line and reached 50% at the peak period at the end of January. These tables are all going to use the same format. They're in your slides if you need to refer to the actual numbers. I'm just going to highlight a few. As we go through the tables, the first column is influenza positives, and then it shows the percentage of those influenza positives that were vaccinated, 42% for all ages. And the next column shows influenza negatives, and the percent of negatives that were vaccinated, 54%. That gives us an unadjusted odds ratio shown there of 38%. And the adjusted overall influenza vaccine effectiveness was 40%, with a confidence interval from 34% to 46%. For the remaining age groups at the bottom against any influenza, the only age group that had a slightly higher vaccine effectiveness was 6 months to 8-year-olds with 53% and a confidence interval from 42% to 62%. All of the other age groups are statistically significant with the exception of 65 and older. The estimate in the 65 and older was 20% with a confidence interval from -9 to 41%. I'm now going to go through the subtype specific estimates. The format is the same for the H3N2 estimate. The adjusted estimate was 24% for H3N2 in any age group with a confidence interval from 15% to 33%. And it was higher in the 6 month to 8-year-old at 37% and not statistically significant in all of the other age groups from 9 to 17-year-olds to 65 and older. For influenza H1N1 PDM09, the overall estimate was 65% with a confidence interval from 55 to 73. The estimates were higher than what we just saw for H3N2 for all of the age groups, with the exception of the 65 and older, which had an estimate that was not statistically significant. And finally, for influenza B, we've subdivided this by B lineage. Against B Yamagata, the overall estimate for all ages was 49%, with a confidence interval from 40 to 56%. And again, the 65 and older were not statistically significant. We do not have an adjusted estimate for influenza B Victoria, but the crude estimate does not suggest that there is a very big difference between the VE against B Yamagata and B Victoria this season. Now I'm going to go to the preliminary end-of-season estimates for the Haven network. The 4 sites are shown here with the principal investigators. 3 of these sites also participate in the U.S. Flu VE network. The Haven network enrolls inpatients 18 years and older. The definition is similar, acute respiratory illness with new or worsening cough or sputum production, except that it is 10 days of duration. The dates of enrollment are slightly wider than what we saw for the U.S. Flu VE network, from October 6th at some sites to April 28th. The test negative design is the same, and the vaccination status for this analysis is all done by self-report. The adjustments are slightly different than what we see for the Flu VE network and include some adjustments for relative frailty, like home oxygen use and number of self-reported hospitalizations in the prior year. The pie graph that you'll see at the bottom is very similar to what we see in the Flu VE network, so the distribution of the positives by subtype and lineage was very similar. There were 3,597 included in this analysis at the 4 sites, including 10 hospitals. 24% of those enrolled were tested positive for flu. That's slightly lower than what we saw in the outpatient setting. 59% were H3N2, very similar to the outpatient setting. B Yamagata was the primary B lineage, although the percentage of all positives that were B Yamagata was slightly lower than the outpatient setting, and the H1N1 percentage was very similar to the outpatient setting. The distribution of positives and negatives enrolled by week is also very similar to the outpatient setting, except that the percentage positive reaches only 35% at the peak, which is actually very high for inpatients with this sensitive definition of acute respiratory illness. There was also some positivity for influenza B. As numbers of enrolled went down, the percentage actually went up quite a bit in the March and April period. The tables are the same format that I showed for the U.S. Flu VE network. Overall, the vaccine effectiveness against any flu in the inpatient setting in adults was 22%, with a confidence interval from 8 to 35%. It was statistically significant only in the 50 to 64-year-old age group at 32%, but all the estimates were quite similar. For H3N2, the overall estimate was 16% and not statistically significant. When we look by age group, again, only the 50 to 64-year-olds were statistically significant, and all of these estimates are quite low. For the H1N1 PDM09, the overall estimate was higher than that we saw for H3N2. Overall, it's 58%, and was statistically significant in the 65 and older. If you remember back to the U.S. Flu VE network ambulatory data, those were the disappointing estimates in the outpatient setting. For some reason that we don't understand, this actually looks very good in the 65 and older in the inpatient setting. And then finally, for B Yamagata, the overall estimate was 35%, slightly lower than we saw in the outpatient setting, but very similar estimates by age group, although none of them are statistically significant. One of the nice things that we can do now with having preliminary end-of-season estimates in June for both the outpatient and inpatient vaccine effectiveness networks is compare the results for adults. So these are vaccine effectiveness by age group among adults, showing the inpatient estimates on the left and the outpatient estimates on the right for each of these three age groups, and the overall all adult age groups in the first column. So we see that the estimates in inpatients are very similar to those in outpatients. I think the take-home message is that the vaccine provides protection not only against outpatient influenza illness, but also against more severe inpatient disease in adults. The estimates for inpatients that you see in the second column for 18 to 49 were not significant, and the estimates for 65 and older were not significant. But the point estimates and the confidence intervals suggest that these estimates are very similar for inpatient and outpatients. And a second very similar slide shows the VE estimates by subtype and B lineage, or at least B Yamagata at the end. And again, the message is very similar. The vaccine provided very similar protection against inpatient and outpatient disease in adults, against H3N2, although disappointing, against H1N1, much higher, and against B Yamagata for all adult age groups. So in summary, the 17-18 season, as you know, was a season with high severity. The H3N2 viruses predominated. The vaccine reduced outpatient visits for influenza-associated acute respiratory illness by 40%, with the confidence interval shown there among persons aged 6 months and older. Among adults, vaccine effectiveness estimates were similar for outpatients and inpatients. Vaccine reduced influenza-associated hospitalization among adults by 22%, with a confidence interval from 8 to 35%. Vaccine effectiveness estimates against H1N1 were 65%, and B Yamagata 49%, were higher than those that we saw against H3N2, which was 24% in the outpatient setting. But this is also similar to what we have seen with previous seasons concerning the lower vaccine effectiveness against H3N2 viruses. Final VE results will include vaccine effectiveness by vaccine type, including an analysis of standard dose versus high dose inactivated vaccine for patients 65 and older, and effects of prior season vaccination. We do expect this year to have averted burden estimates in the fall for the 17-18 season, and we expect them to be greater in terms of averted burden or the burden of influenza prevented by vaccination than what we saw in 16-17. The comparative estimates for vaccine coverage and vaccine effectiveness for the 16-17 and 17-18 season are shown in the upper right. You'll see that our estimates are very similar, and we know that the actual burden of influenza was much higher in the 17-18 season, and so we expect to see higher numbers than what we saw for averted burden in 16-17. These numbers are published on the CDC website. There were 85,000 hospitalizations prevented in 16-17, 2.6 million medical visits, and 5.3 million influenza illnesses based on models that the CDC has developed. And finally, CDC is continuing to try to work towards better vaccines and expand the evidence base for especially the H3N2 virus, low vaccine effectiveness. Some of the ongoing work includes investigation into the immune response, especially among vaccine failures or people who get influenza despite having been vaccinated. One of the things that we're doing for that is both in the U.S. Flu VE network and Haven networks, patients who test positive for influenza will have acute and convalescent sera collected to look at the immune response at the time of infection. That's one gap in our knowledge right now in terms of the response to the natural infection, as well as the acute phase response in vaccinated people that will help us to understand vaccine failures. The second activity that includes or involves the U.S. Flu VE network and Haven is increased funding to expand enrollment. That will help us to get more data, especially by vaccine type, in the 17-18 season. That is related to the next bullet on expanding evidence for the contribution of antigen dose, high dose and standard dose, especially in the 65 and older, but also concerning dose in some of the other vaccines, as well as adjuvanted vaccine. We also hope to be able to understand the effects of egg-adaptive changes that have received a lot of coverage in the media this year and a lot of attention from ACIP, and the presentation from FDA will begin that process of providing data to ACIP on some of the differences between egg-based and non-egg-based vaccines that we hope to be able to continue with the flu vaccine effectiveness networks next season. Right now we have just too few non-egg vaccines in the flu vaccine effectiveness networks being used to be able to provide estimates to you at this time. And then finally, a much larger effort at CDC is ongoing to engineer optimal vaccine viruses that have fewer egg-adapted changes and hopefully be able to improve the vaccine effectiveness overall and not just for H3N2 viruses. With that, thank you very much.
Thank you very much. I think we'll go on to Dr. Liu's presentation and then take questions on both after.
Good morning. My name is Yun Lu. I'm from FDA CBER. So today I'm going to present results from a real-world evidence study, relative vaccine effectiveness of cell-cultured versus egg-based influenza vaccines for the 2017 and 18 season. This is the joint work of FDA, Centers for Medicare and Medicaid Services, and ACIP. This is my disclaimer. 2017 and 18 is a H3N2 predominant season. A CDC-sponsored interim analysis showed a low vaccine effectiveness among U.S. individuals 65 years and older. Because most of the influenza vaccines were prepared in chicken eggs, and one hypothesis is that egg adaptation could lead to lower vaccine effectiveness during this 2017 and 18 season. So we studied the relative effectiveness of cell-cultured versus egg-based vaccines among Medicare beneficiaries 65 years and older. The observational period of our study is from August 6, 2017 to April 20, 2018. Our exposures included 5 types of influenza vaccines. Because all the cell-cultured vaccines are quadrivalent, A direct comparison group is egg-based quadrivalent vaccine. We also included 3 egg-based trivalent vaccines, high dose, adjuvanted, and standard dose. Our population are Medicare fee-for-service beneficiaries who received any of the 5 types of influenza vaccines, and the exposures and outcomes were identified using Medicare Health Claims Code. The primary outcome was influenza hospital encounters, which include both inpatient hospitalizations and emergency department visits with influenza diagnosis code. The secondary outcome was influenza-related office visit, which include physician's office or outpatient non-ER visit with a rapid influenza diagnosis test and followed by prescription of antiviral treatment. The post-hoc outcome was influenza inpatient hospitalizations only. All the outcomes were measured during high influenza circulation periods. Starting from our base population, beneficiaries who received any of the 5 types of influenza vaccines from August 6, 2017 to January 31, 2018, we applied inclusion and exclusion criteria. Okay. So these slides showed our final study populations. So we can see vaccine uptakes varied. The cell-cultured quadrivalent vaccine had the lowest uptake with about 0.65 million beneficiaries in the final study population. And egg-based high-dose vaccine had the highest uptake, include about 8.4 million individuals. Because we're using real-world data, our data reflect the exposure experience of the actual vaccine recipients during routine clinical practice. And we want to make sure that the 5 vaccine cohort were comparable. So we compared covariate balance for 62 demographics and health utilization covariates. And a standardized mean difference of less than 0.1 would indicate negligible imbalance. Again, we're using real-world data, and the data showed the actual covariate distribution. About half of the 62 covariates were initially imbalanced. To address this imbalance, we used inverse probability of treatment weighting. And the following weighting, the standardized mean differences were less than 0.05 for all the covariates, which indicate that the covariates were well balanced. So this table showed selected number of covariates which were initially imbalanced before weighting. We used red color and blue color to indicate vaccine cohorts that had the largest imbalance. So the first covariate was Vaccinate at pharmacy. It showed the percentage of people who vaccinate at the pharmacy setting. And we can see that our direct comparison group, egg-based quadrivalent cohort, has the lowest percentage of being vaccinated at the pharmacy setting, 9.2%. And the high dose and adjuvanted, they had the highest percentage of being vaccinated at the pharmacy, 44.4% for high dose and 67.5% for adjuvanted. The last covariate was no prior outpatient non-ER visits. This covariate could potentially be associated with health-seeking behavior. And we can see the cell culture vaccine group had the highest percentage of no prior outpatient non-ER visits, 43.5%. And the direct comparison group, egg-based quadrivalent cohort had the lowest percentage, 32.2%. And after waiting, all the standardized mean difference were less than 0.05, which indicate that all the measured covariates were well balanced. However, inverse probability of treatment weighting did not necessarily address imbalance for unmeasured potential confounders. This is an issue we often found when using real-world evidence. So after waiting, we obtained the relative vaccine effectiveness using univariate Poisson regression. The next slide showed our study results. We include both the 2 vaccine and the 5 vaccine comparison results. For both analysis, we use egg-based quadrivalent vaccine cohort as the reference group. The top 2 figures showed the 2 vaccine comparison results. The top one is for primary outcome, influenza hospital encounters. And the second figure was for our secondary outcome, influenza-related office visit. We can see both outcomes gave similar results. Cell-cultured quadrivalent vaccine had about 10% relative vaccine effectiveness compared with the comparison group egg-based quadrivalent, which means that cell-cultured quadrivalent is 10% more effective compared with egg-based quadrivalent in our study for both the primary and secondary outcomes. The bottom graph showed the 5 vaccine comparison result for the primary outcome, influenza hospital encounters. Both cell-cultured quadrivalent and egg-based high-dose vaccine had better vaccine effectiveness compared with reference group egg-based quadrivalent. And egg-based adjuvanted are slightly better compared with the reference group. So this slide showed the 2 vaccine comparison results and results from our sensitivity analysis. The top graph showed results from our primary outcome, influenza hospital encounters. The middle graph is secondary outcome, influenza-related office visit. And the bottom graph showed result from our post-hoc outcome, influenza hospital encounter with inpatient only. So the left column, the first column, was our primary analysis results. You can see that all the 3 outcomes give us similar results. The point estimate is around 10%. When we conduct analysis, we use inverse probability of treatment weighting because some of the beneficiaries, they had large weights. To reduce the impact of those high weight outliers, we truncated the weight to 5 in our primary analysis. So we want to know what's the impact of those truncation. So for our first sensitivity analysis, which is the second column, we use non-truncated weights, and we can see that the results were very similar. We also conducted a second sensitivity analysis, which was shown on the last column. It's a doubly robust method. We also included those 62 covariates in the Poisson regression instead of using univariate Poisson regression, and you can see that our results are also relatively robust. This slide is very similar to the previous slides with regard to setup. The difference is now we present results from the 5 vaccine comparison study. Okay. So again, the top graph showed the result from our primary outcome, hospital encounters. And the middle graph showed our secondary outcome, influenza-related office visit. And the bottom graph is our post-hoc outcome, inpatient hospitalizations only. And we can see that the primary outcome and our post-hoc outcome, hospitalization outcomes, gave very similar results. Both the cell-cultured and egg-based high dose had better vaccine effectiveness compared with the egg-based quadrivalent vaccine cohort. And also the result was not very sensitive to those two sensitivity analyses. However, for the middle graph, which was the office visit outcome, you can see that the results were inconsistent. So as I mentioned in the table before about the selected number of imbalanced covariates, we can see that there are some imbalances with regarding to percent of receiving vaccination at the pharmacy setting. There are differences with regard to possible different health-seeking behaviors. So we are currently conducting analysis to investigate the office visit outcome. We're also comparing pharmacy versus non-pharmacy cohort to explore potential sources of bias. Okay. So our study has several strengths. We're using Medicare claims data, and the data include nearly all of the actual vaccine recipients aged 65 years and older nationally. We're using real-world data, and our data reflect the exposure and outcome experience during routine clinical practice. So, unlike carefully selected subjects in clinical trials, our Medicare beneficiaries have a wider range of health conditions. And we have a large data set. Our final study population included more than 13 million beneficiaries. And this large data set provides power to detect small but clinically relevant differences and analyze rare serious outcomes. However, our study also has several limitations because real-world data are not collected or organized with the goal of supporting research, nor have they typically been optimized for such purposes. We're using health claims data, and there are potential exposure and outcome misapplication. There are potential unmeasured confounders even after adjusting for measured covariates. And as we have shown in the previous slides, influenza-related office visits outcome results were inconsistent. We're using health claims data, and there's no virological case confirmation, and we cannot differentiate between AH3N2, AH1N1, or B infections. There exists processing delay in health claims for exposure and outcome codes. So we're planning to conduct an end-of-season analysis after we receive complete data. In summary, in this analysis, the cell-cultured and high-dose vaccines were marginally more effective than the egg-based quadrivalent vaccines for hospital outcomes among U.S. people 65 years and older during this 2017 and 18 season. And these findings contribute to growing evidence base about new and enhanced vaccines compared to traditional vaccines. And this is the first comparison of several new and enhanced vaccines to both the egg-based traditional vaccines and also to each other. And because relative vaccine effectiveness could vary from season to season, we will continue to monitor RVE for additional seasons. Findings from this single observational study should be considered as a part of the entire body of evidence. While cell-cultured and high-dose influenza vaccines appear to offer some additional benefit to people 65 and older, further efforts are needed to improve influenza vaccine effectiveness. And the relative vaccine effectiveness could vary from season to season. Data from more seasons are needed. We are using Medicare health claims data, and the results from similar studies conducted in different settings or health systems would provide important context for our results. And we will continue to investigate ways to minimize and quantify potential sources of bias in real-world evidence studies. So here is the list of our team members from FDA, CMS, and ICMN. And I want to thank our colleagues from FDA and the CDC for their helpful input. So I'll be happy to answer questions. Thank you.
Thank you very much. So do we have questions for Dr. Flannery and Dr. Liu? Yes, Dr. Riley.
This question is for Dr. Flannery. I'm assuming because you didn't report it that we don't know who's pregnant in these different cohorts?
Yes, that's correct. We don't collect pregnancy status routinely from all of the sites.
So in your last slide on enhancement, can I make a plea that we start getting some pregnancy data? Because it's really difficult to convince patients that it is beneficial to them when we never are really able to say it is beneficial to you in any way. So I think it's really important. And then the other thing is, which I'm sure is much more difficult to extrapolate, but I think if we had some sense of the degree of disease in children less than 6 months of age, that would also be a reflection of whether or not maternal immunization is helping. And I realize why you're only reporting greater than 6 months of age, but it would be nice to have that information together.
Yeah.
Thank you.
Just to comment, we have looked both at collecting information on pregnancy in these networks as well as in a pandemic setting looking at using these networks for children less than 6 months of age to look at the effects of maternal vaccination. The take-home is that these may not be the best platforms to be able to do that because we don't have a lot of pregnant women in the VE network in our enrollment, and it may need to have a special approach to enroll women from places where they would seek care with acute respiratory illness during pregnancy, and then for recruitment of young infants, a special recruitment as well. Thank you.
Dr. Fry?
Yeah, thanks for your comment. Like Brendan said, we have a hard time in our routine platforms, but we do have some special studies. So we have some data for with an estimate of VE against a hospitalized outcome in pregnant women, and we'll present that to the working group this summer.
Actually, if I could add one similar question. You mentioned in Haven that the vaccination data is all self-report, and I wondered if there's a plan to change that to have better data on what kind of vaccine people received, which you would be unlikely to get through self-report.
Yeah, the only reason that we present the self-report data now is that we have the self-report complete for all the sites. Once we have the final vaccination histories and documentation for the season, the Haven Network will present to the working group on vaccine effectiveness by vaccine type.
Thank you. Other questions? Dr. Baker.
This is for Dr. Yen. 2 clarification questions. You presented in your slides the interval by dates, but I think I heard you say that some of the data was analyzed by the high flu interval. So was it all during the dates that you put on your slide that you measured influenza? And then I have a second question, is how was the diagnosis of influenza made in the inpatients and outpatients?
Okay. Yeah, so I will first answer the first question. So on the slides, I mentioned that all outcomes were measured during the high influenza circulation period. So we use a 15% cutoff, that is the percent of test positive. And then if we have percent test positive higher than 15, we consider that as a high influenza circulation period, and then we record that outcome. And then we didn't include influenza outcomes which happened during the low influenza circulation period. Yeah. And the second question about how the outcome were measured. So first, we're using the Medicare health claims data. We're looking at ICD code. So currently, we're looking at ICD-10 code, and for the hospitalization outcome, we look at inpatient hospitalizations with influenza diagnosis code. And then we also included emergency department visit with influenza diagnosis code. And about our secondary outcome, office visit outcome, we look at a different set of code. Instead of looking at office visits with influenza diagnosis code, we look for code which indicate rapid influenza diagnosis test and followed by prescription of antiviral treatment of the within 2 days after the test. Okay. So for this secondary outcome, we also apply more inclusion criteria because we require the beneficiaries to have Part D enrollment as well. So for the hospitalization outcome, we only require them to have the continuous Part A and B enrollment. We didn't have Part D enrollment requirement. Yeah. So did I answer your question? Okay, thank you.
Thank you, Dr. Hunter.
I'm not sure you will be able to answer this, but it's more of a question for us as a committee, I think, a broad question of how much do we want to compare vaccine effectiveness between different influenza vaccines? If they each may vary more from season to season than the difference between the vaccines within a season. Because I'm seeing in the cell culture versus egg-based cultures a relative difference of 10% being a pretty small difference, especially if you're looking to see what the absolute difference is between them in order to calculate from a clinician's point of view what the number needed to vaccinate is. I'm calculating a number needed to vaccinate for vaccinated versus not vaccinated as about 10 to 20 based on the absolute differences that I quickly looked at of 5 to 10% between vaccinated and not vaccinated in the different age groups. So I just wanted to throw that out there. I'm not sure that anybody can answer my main question of whether we want to be looking at this and basically do we want to be looking into this black box or underneath this hood, because from a practical point of view, it's going to change so much season to season that in a clinical setting or a population setting, implementing this, the difference is not going to be that big of what we say. How can we really make a decision in advance of a season? We don't know what the relative difference is going to be.
Thank you. I think that's the $64 million question. Dr. Messonnier.
Yeah. We value ACIP's opinion about how to interpret this data and what the relevant questions are that would drive an ACIP decision. And so while the difference of a question is whether or not any data at this level would be enough for you to make a different opinion, but we would still want you to continue to look at the data with us. As you can imagine, policymakers throughout the U.S. government and other countries are asking these questions. What can we do to incrementally improve vaccines given the current technology? And so we really count on you to help us hone our thinking. And that question about sort of number needed to treat is a great question and a great way for us to look at this data, to come up with an estimate of how much of a difference you'd have to see. So we would value your continued looking at the data.
My comment on that is, yeah, I really want to see this data, but I don't know if it's going to change what I think about what to do about it. That doesn't mean I don't want to see the data. Yeah.
Right. Thank you. Okay, I'm going to take 2 more questions, then we're going to move on. Dr. Atmar?
I just wanted to comment on your outpatient surveillance definition requiring rapid influenza testing. I know our health system has basically removed the ability for outpatient physicians to do rapid influenza testing because of the poor sensitivity, particularly in adults. And so I would be interested to know, if you have the information, how many had a diagnostic code but didn't have the rapid influenza test to support that, because many guidelines actually recommend that the decision to treat or not to treat be made based on the clinical presentation, not on the diagnostic test because of its poor sensitivity.
Yeah, actually, we are conducting analysis looking into this influenza-related office visit outcome. We saw some differences regarding the percentage of testing percent of treatment across regions. And so the results are not ready to present at this time, but we are looking into this, and we did see some difference. We see that for some regions, they have a higher percent of being treated without test. But other regions, they may have a higher percent of being tested. Yeah. So again, we're doing the analysis, just the data are not ready to present at this time.
Dr. Stevens?
This is for Dr. Liu. My question has to do with the covariants. There are some 60 covariants that you looked at, and did those include medications, underlying disease, and did you look at that from a perspective of any influence on the data?
So for those 62 covariates, we include lots of covariates. You can see by number. So we have age category, we have race, we have gender, we have HHS regions. We also include dual eligibility to indicate their income status. We also have their health conditions. There is a complete list. So if you're interested, I can provide the list. It's hard for me to go through all of the covariates, but yes, we did include covariates which indicate their underlying health conditions.
And medications?
Let me check. I have the list here. Just want to make sure. I think we have some medications. Okay. So for some conditions, health conditions, I think we use some medication, but I'm not sure at this time completely what type of medication are included. So, but I will provide information to you later. Just make sure that I provide accurate information. Okay.
Thank you. Dr. Lee, I'm breaking my own rule. We're doing 2 more questions.
I'm sorry. I just wanted to ask if you are also looking at the potential impact of the distribution and the vaccines that are given. Specifically, I was noticing for the dual eligibles, the distribution looks very different than when you're giving it in the pharmacy, and whether that leads to potential disparities as a consequence of what we're seeing today.
Yeah, we are currently investigating the pharmacy versus non-pharmacy setting to look into the difference of those covariates to explore whether there are potential sources of bias. Yes, we are doing that right now.
Just to put a fine point on it, differences in the outcomes for the patients. So is the distribution of vaccines that we provide resulting in different outcomes for patients?
Yes, right. So we're not only looking at difference in the distribution of the covariate, but also looking into the impact on the outcome, on the results.
Dr. Boulanger, did you have one last question?
Very briefly, I just wanted to point out, too, that over the next year or two, we should be getting a lot more data in terms of the relative performance of non-egg-based vaccines versus egg-based vaccines using laboratory-confirmed outcomes.
Oh, that'd be great.
Thank you. Okay, I think we'll move on to safety.
Good morning. I'll be giving an end-of-season update on 2017-2018 influenza vaccine safety monitoring. These are the standard abbreviations that I'm sure most of you are familiar with and I'll be using throughout the presentation. I'll start off with Vaccine Adverse Event Reporting System, or VAERS surveillance. So just to remind you, VAERS is our spontaneous reporting system that's co-managed by CDC and FDA. It allows for rapid detection of safety signals and can detect rare adverse events, subject to the limitations of spontaneous reporting. So generally, we cannot assess causality from VAERS data alone. So we looked at U.S. influenza vaccine reports. Signs and symptoms and diagnoses are coded using MEDRA terms. We did a clinical review of reports, which includes medical records when available for all serious reports, pregnancy reports for spontaneous abortion, stillbirth, congenital anomalies, and serious pregnancy reports, and anaphylaxis reports in persons with a history of egg allergy. Our FDA colleagues conducted empirical Bayesian data mining to detect disproportional reporting of vaccine adverse event pairings. So this is a table of U.S. reports to VAERS following standard dose, trivalent, standard dose, quadrivalent, and high-dose vaccine. And the raw numbers are not so important for safety surveillance, so they may be somewhat indicative of use. The thing to focus on is the percentages. So for these products, 94 to 96% of reports to VAERS were classified as non-serious, and that's consistent with what we've seen in previous seasons with these products. Serious reports were 4 to 6%. Just want to make the point that these are spontaneously submitted reports to VAERS that meet the regulatory definition of serious. This does not mean that 4 to 6% of individuals that get a flu vaccine have a serious adverse event. Again, this is passive surveillance, spontaneous reporting. And there were no data mining signals for Guillain-Barre syndrome or anaphylaxis in association with standard dose, trivalent, quadrivalent, or high-dose vaccine. So this is the same table for some of the other products: cell culture, adjuvanted, recombinant, and intradermal. And again, focusing on the percents, non-serious reports range from 94 to 98%, which is consistent with the other vaccine products I just showed you and consistent with what we've seen in previous season with these products. There are no data mining signals for Guillain-Barre syndrome or anaphylaxis in association with any of these influenza vaccine products. So this table is reports to VAERS following vaccination during pregnancy. There are 59 total reports, and you see the product types on the top line. Median maternal age at vaccination was 31 years. Median gestational age at vaccination, when gestational age was reported, was 16 weeks. A plurality of reports with trimester documented had individuals vaccinated in the first trimester, although you see the spread there between the 3 trimesters is pretty even. 13 of these 59 reports, or 22%, reported a pregnancy-specific adverse event, of which spontaneous abortion and morning sickness were most commonly reported. 19, or 32%, reported a non-pregnancy-specific adverse event. And 27, or 46%, did not document an adverse event. So those are vaccination errors or perceived vaccination errors. So in summary, for VAERS, there were no new safety concerns detected for any of the influenza products during the 2017-2018 influenza season. Surveillance for the 2018-2019 influenza season will include enhanced safety monitoring for adjuvanted influenza vaccine, recombinant, quadrivalent influenza vaccine, pregnancy reports, and anaphylaxis reports in persons with a history of egg allergy. So moving on to Vaccine Safety Data Link Rapid Cycle Analysis for the current season. So the VSD is our large link database, which has data on over 10 million persons per year, and it links vaccination to health outcome data. We conduct annual influenza vaccine surveillance in VSD, and it's also the system we use to conduct epidemiologic studies. RCA is weekly near real-time sequential monitoring to detect statistical signals for pre-specified outcomes. It includes methods to adjust for sequential testing. We focus on standard dose IAV3 and IAV4 and high dose, and I'll be presenting the results for standard dose IAV3 and IAV4 in this presentation, specific results. Uptake of other influenza vaccine products is still relatively low. There are 2 designs we use for rapid cycle analysis. One is self-controlled risk interval. That's where each patient serves as their own control. And you are looking for clustering of events in a biologically plausible risk window compared to a comparison window. Current versus historical is looking at incidence of events in the risk window in the current season compared to incidence in a historical period. These are the pre-specified outcomes. They haven't changed from the previous season. They are acute disseminated encephalomyelitis, anaphylaxis, Bell's palsy, encephalitis, Guillain-Barre syndrome, seizures, and transverse myelitis. You see the age group breakdown, the risk windows, and the control windows for the outcomes we analyzed using the self-controlled risk interval method. This is some data on dose 1 influenza vaccine doses administered in the VSD. Standard dose IV3 and IV4 is about 83% of total doses. And there was a substantial amount of high dose as well. The total number of doses was 5.3 million during the analytic period that I'm reporting on. So I'm going to run through a series of tables, and these tables are primarily in here as reference tables and for transparency. I'll just go through this table, just explain what you're looking at, and then I'll flip through the other tables pretty quickly. You have the pre-specified outcomes, again, the risk interval, age group, doses, events in the risk window, events in the control window, the relative risk, the log likelihood ratio, and the critical value. And this is for standard dose trivalent for the self-controlled risk interval design. So if the log likelihood ratio, if you can see my point here, if this value right here exceeds the critical value for any of these outcomes, that will meet the threshold for a statistical signal. As you can see, the log likelihood ratio did not exceed the critical value for any pre-specified outcomes for standard dose trivalent in the self-controlled risk interval design. This is a similar table for standard dose IV4 self-controlled risk interval design. Again, the log likelihood ratio did not exceed the critical value for any pre-specified outcomes, so there are no statistical signals. This table is for standard dose trivalent. This is the current versus historical design. And again, the log likelihood ratio did not exceed the critical value for any pre-specified outcomes. The last table I'll show you is standard dose IV4, current versus historical design. And you see by my highlight there, anaphylaxis with a risk interval 0 to 2 days. There were 11 observed cases, 4.2 expected cases. The relative risk is 2.62. The log likelihood ratio is 3.8. That exceeds the critical value of 3.67. So that meets the threshold for a statistical signal that we need to analyze further. So this statistical signal was detected the week starting October 15. There are 9 cases observed, 1.13 cases expected, for a relative risk of 8. By the week starting November 5, there were 10 cases observed and 2.06 cases expected. Upon chart review of these 10 cases, 9 cases had symptom onset prior to vaccination, 5 with possible or probable environmental triggers. 1 case was a probable case with onset approximately 12 hours after vaccination and no other suspected triggers. So the signal was not confirmed after chart review. There was 1 additional anaphylaxis case detected in January. That was not reviewed because it wouldn't have changed the final results. So in summary, there are no confirmed RCA signals in either of the analyses. The data for high dose, cell culture, adjuvanted, recombinant, and intradermal doses was limited due to low use, but were generally reassuring. For next season, we'll conduct self-control risk interval and current versus historical RCA using the same pre-specified conditions and risk intervals. For next season, we are going to combine IV3 and IV4 into a single category for monitoring, but if a statistical signal is detected, we'll analyze these vaccine types separately. So I'm going to be presenting, next I'll be moving into FDA's monitoring of Guillain-Barre syndrome following influenza vaccination and Medicare beneficiaries. I'm presenting on behalf of my FDA colleagues in CBER. So FDA's approach is to do near real-time surveillance using updating sequential probability ratio testing during weeks 7 to 11 of the vaccination season. They also do descriptive statistics for the entire season and do a self-controlled risk interval end-of-season analysis. Again, they use the Medicare data, and they're looking at influenza vaccination and GBS diagnosis as the primary discharge diagnosis from data sets that include the common working file and the shared systems data. These are just essentially two Medicare data sets. So FDA uses a 5-year historical cohort as the comparison group. Their primary risk window for GBS is 8 to 21 days. They also use a secondary risk window of 1 to 42 days post-vaccination. The null hypothesis is that the observed rate should not be higher than 2.5 times the expected rate based on historical data. They also do some subgroup analyses as well. So this shows vaccine uptake during the season, and you see those two critical periods there, week 7 through 11, starting September 29th and October 27th. And then you see the uptake for the different product types during the course of the influenza season. So this is two figures showing data from the two different data sets that I previously mentioned. So what you're seeing here is the observed GBS rate, that purplish red line, the expected rate, and then you have the critical value, the 2.5 times above, in that specific 7 to 11 week window that they're doing their sequential testing. As you can see, for both data sets, there was no signal for a potential 2.5-fold increased risk of GBS compared with the 5 prior historical seasons used as controls. So they also conducted an end-of-season self-controlled risk interval analysis. Again, they use day 8 to 21 as their primary risk window and a 1 to 42 as their secondary. This is similar to the way CDC conducts self-controlled risk interval as well. Used vaccination data up to January 5th and GBS cases up to May 18th. So this is just the vaccine doses administered. You can see they have a little over 8 million high dose doses. So there's substantial use of IV high dose in the Medicare population, as you might expect. So this table shows the primary risk window analysis and the secondary risk window analysis, unadjusted and adjusted. And the odds ratios in both analyses are around 1, and the 95% confidence interval includes 1. So there are no statistically significant increased risks using the self-controlled risk interval end-of-season analysis. So in conclusion, FDA's near real-time surveillance did not show a risk of GBS higher than the pre-specified testing threshold. And the self-controlled risk interval end-of-season analysis using all seasonal influenza vaccines did not show any statistically significant GBS risk in the 8 to 21 or 1 to 2 42 days post-vaccination risk interval with and without seasonality adjustments. And these are our FDA colleagues that contributed to this section. And I'm going to wrap up reporting on a couple of studies in our clinical immunization safety assessment project. First one I'll describe is titled Safety and Immunogenicity of Fluad versus Fluzone High Dose in Older Adults. This is a randomized clinical trial. Adults age 65 and older are randomized 1-to-1 to receive Fluad or Fluzone High Dose. And there are safety outcomes collected for 42 days after vaccination, and there's also immunogenicity testing as well. Participants are enrolled from 3 sites this past season and this next season. The goal is 880. Currently we have 279, and again, we'll be enrolling this season as well. And a safety panel of 3 vaccine safety experts who are not investigators reviewed the interim safety data from this past season on June 6, 2018. Each panel member concluded there were no substantial safety concerns observed. And lastly, I want to report on the CISA study fever after simultaneous versus sequential vaccination in young children. This is a randomized clinical trial. Children aged 12 to 16 months were randomized 1-to-1 to receive a simultaneous or a sequential schedule. And these schedules were, for simultaneous, was PCV13, a DTaP-containing vaccine, and IIV4 at visit 1, and then a health education visit 2 weeks later. The sequential arm had PCV13 and DTaP together on visit 1, and then on visit 2, IIV4 and a health education visit. And the primary outcome was fever. The investigators enrolled and randomized 221 children during the 2017-2018 season. Enrollment actually had to be paused because of widespread influenza activity, and we weren't comfortable delaying that IIV4, and this analysis is in progress. So I'll be happy to answer questions.
I think maybe we'll go on to the SOMNIA trial and then have questions, if that's all right.
Sure. Okay, moving on to the systematic observational method for narcolepsy and influenza immunization assessment, SOMNIA. It took about as long to generate that acronym as it did to do the whole study. But it's important to have a good acronym. So this is a study to assess the risk of narcolepsy following adjuvanted 2009 H1N1 influenza vaccines. This is our study team. This is a large, multi-site, multi-country international study involving a lot of coordination. It is led by Steve Black, Miriam Sturkenboom, and Daniel Wiebel. And you can see how many folks were involved and how many sites were involved. I'm going to discuss the background and rationale, and then present results from the incidence rate arm, the case control arm, and then conclusions. So before I start the background and rationale, this presentation is a little bit odd in that actually most of the presentation is going to be spent talking about the background and rationale, and then briefly I'll discuss the high-level main findings of the study. So if you're familiar with the issue of narcolepsy following adjuvanted influenza vaccines, you'll probably understand why I'm doing this. If you're not, just go with it, and hopefully afterwards you will understand why I'm taking so much time kind of setting this up, and then I'm going to really present the high-level findings. So this is a posting from the Swedish Medical Products Agency dated August 18, 2010, announcing that the agency is investigating reports of narcolepsy in patients vaccinated with Pandemrix. And Pandemrix is a monovalent AS03 adjuvanted influenza A H1N1 vaccine manufactured by GSK that was widely used in Europe during the pandemic and was widely used among a lot of Scandinavian countries. So what is narcolepsy? Narcolepsy is a central nervous system disorder characterized by excessive daytime sleepiness and abnormal manifestations of REM sleep. It includes sleep attacks, disrupted nocturnal sleep, sleep paralysis, hypnagogic hallucinations, and cataplexy. Cataplexy is the sudden loss of muscle tone, basically lose control and you're not able to stand, fall down, can often be triggered by emotional events or responses. Narcolepsy is a chronic disease. It's treated with medication and behavior modification, but there is no cure. There are two diagnostic entities, narcolepsy with cataplexy and narcolepsy without cataplexy. A Brighton collaboration case definition exists. It's primarily based on presence of symptoms and an abnormal multiple sleep latency test characteristic of narcolepsy. It's thought to be caused by damage to hypocretin-secreting neurons in the hypothalamus, and it's strongly associated with the HLA DQB10602 allele, which is present in 5 to 38% of people. So it's not rare. And what this really means is nearly everybody who has narcolepsy with cataplexy has this HLA allele. but most people who have this don't have narcolepsy with cataplexy. It's thought to be autoimmune and a multi-event process. Suspected infectious triggers include febrile illness, influenza infections, and beta hemolytic streptococcal infections. Onset can occur at any age but peaks during teenage years. It's very rare under age 5, and it's rare after age 40. Prevalence estimates vary widely across countries and regions, and there's often a long delay from symptom onset to diagnosis. It can be many years. So this is the Pandemrix Narcolepsy Timeline. In October and November 2009, large-scale vaccination programs were implemented in many European countries. Then in February 2010, a Finnish narcolepsy expert discussed this association with narcolepsy following Pandemrix with some of his colleagues. By August 2010, there was extensive media attention and regulatory attention around an association in children and adolescents. And about this time, there were studies in Europe undertaken to further assess this potential association. The SOMNIA study planning started in earnest around 2012. So the problem of studying narcolepsy is this issue of dealing with the potential impact of awareness. So what you see on top is a kind of a schematic of the narcolepsy timeline, where the initial symptom is excessive daytime sleepiness. There's other things that come with excessive daytime sleepiness, like problems concentrating, poor school performance, behavioral problems. If you're a young adult, problems with employment, holding a job. Somewhat nonspecific. This can go on for a long time before an individual is referred to a specialist for a workup, gets a multiple sleep latency test, and ultimately receives this narcolepsy diagnosis. This lag time can be years, some cases decades. So the question is, what will happen upon awareness, like there was in Europe in 2010? And this little cartoon on the right is a person shaking a tree. Analogy is, these apples would have ripened and fallen during the normal course of apples ripening and falling, as would narcolepsy cases being diagnosed during the normal course of diagnosing narcolepsy based on the epidemiology and how the health system functions, this top schematic here. However, awareness, which could be this person shaking the tree, can cause these apples to fall out, these cases to fall out. And if you're looking at a short time window, you could get the impression that there is a cluster of narcolepsy and temporal association with vaccination. And in the case of Pandemrix and narcolepsy, the impact of the change in lag time among vaccinated cases appears most prominent early after the signal and may subside later, and I'll show you some evidence of that a little bit later in my presentation, and there's some work going on to model that out. So this is a figure from a paper looking at European studies on Pandemrix and narcolepsy in children. And I think the take-home here is the overall trend is for an increased risk, whether that's an odds ratio or relative risk, depending on the study design, increased risk of narcolepsy associated with Pandemrix vaccination. However, that's not the case in every study. The point estimates vary pretty widely, and these confidence intervals are quite wide as well. This is a similar graph looking at data from adults. You can see there might be some evidence of an increased risk. However, it's not nearly as striking as the previous graph where you're looking at children. And many of these adult studies did not show an increased risk of narcolepsy following Pandemrix. So prior to the SOMNIA study, many studies in Europe, there were many studies in Europe, some with variable results within the study and limited power to produce definitive results. Media and regulatory awareness might have impacted diagnosis patterns in European countries. This is challenging to control or account for because of the short period between vaccination and awareness, and there is no clear biologic mechanism to explain the findings. So the rationale for the CDC-sponsored SOMNIA study was to inform pandemic preparedness for influenza vaccines. further evaluate AS03 adjuvanted pandemic vaccines and address the lack of data on MF59 adjuvanted vaccines. The scope really feeds from the rationale. Our objectives were to evaluate any trends in incidence rates over time of narcolepsy diagnoses and evaluate a possible association between vaccination, infections, and narcolepsy. So moving on to the incidence rate study. These are the study sites and the adjuvanted vaccines that were used in these study sites. Some of these study sites also use unadjuvanted vaccines as well, but I'm listing the adjuvanted vaccines that they used. Arapanrix is a monovalent AS03 adjuvanted influenza A H1N1 vaccine manufactured by GSK at the ID Biomedical Corporation in Canada and was used in Canada during the 2009 H1N1 influenza pandemic. I just previously discussed pandemic, and Fosetria was Novartis's MF59 adjuvanted vaccine that was used worldwide. So this is a dynamic retrospective cohort study. The periods we looked at were before the H1N1 pandemic, during the H1N1 pandemic, but pre-vaccination, and then during and post H1N1, during and post the pandemic and pandemic H1N1 vaccination. So we looked at trends and incidence rate ratios between the periods. So this graph shows incidence rate data from Sweden versus the other countries that I previously listed. And Sweden was an a priori identified signaling country, which we used as a comparator for the other countries. And what you're seeing here is there's a dramatic increase in incidence rate, particularly in the 5 to 19-year-old age group in 2009 in Sweden, maybe less so in the 20 to 59-year-old age group. That's the green line. And then starting to come down in 2011. If you look on the right, this is the rest of the data combined, it's flat. So there's no change in incidence rates over time in any of the countries or age groups beyond Sweden post-vaccination and Taiwan during circulation of wild-type pandemic H1N1 virus. So a little more on Taiwan. This figure shows data from Taiwan, the incidence rate ratio data split between two age groups. That dotted line is just splitting the 5 to 19-year-old age group on one side and the 20 to 59-year-old age group on the other. So again, the pre-H1N1 incidence rates, that's the referent group. In the middle there, you have during H1N1, but prior to vaccination. So this is the period when disease was circulating, but they hadn't started vaccinating yet. And then post-vaccination is during the pandemic when vaccination was going on or after vaccination. And you can see the incidence rate increased in Taiwan during wild-type virus circulation before vaccination and actually went down after vaccination. And most of the vaccine used in Taiwan was unadjuvanted vaccine. The unique thing about Taiwan is they had a short diagnosis lag time compared to other countries. The time period from when a child or a person experiences excessive daytime sleepiness to when they get referred to a specialist, get a sleep study, and get diagnosed with narcolepsy is very short relative to other countries. It's about 2 months. So their data is a little bit unique, but I will say there is some data out there of evidence of an association with wild-type disease and narcolepsy from a study in China as well. So moving on to the case control study. So these are the study sites and the adjuvanted H1N1 vaccines used at these study sites. This is a retrospective case control study. The primary index date was multiple sleep latency test referral. The secondary was excessive daytime sleepiness or cataplexy onset. The reason we had to use MSLT referral as the index date is because actually determining when excessive daytime sleepiness begins is quite difficult. In some cases, you can't determine it, or it's vague, like a year ago or 2 years ago, and you can't really say. So we used MSLT referral as the primary. However, we did do a sensitivity analysis using EDS or cataplexy onset, and the results were similar. So when I mentioned there were two main analyses we did, a restricted period and a total period. So I mentioned the problem of detection bias based on media awareness, where you may have an apparent clustering of cases because you've basically narrowed that lag time. One way to address that issue is to basically censor the data when you think media awareness might be impacting detection of these cases. So you're excluding those cases, and the total period analysis would just be running that out to the end, in this case out to 2015 for most countries, and including those cases that might have been artificially clustering. The restricted period analysis and the total period analysis had similar results. So I'm presenting the total period analysis because we think that the total period is a more robust analysis. So these are the odds ratios and the 95% confidence intervals for the case control study. So for Aripandrix, the case control data came from Ontario, Canada. This was Aripandrix was only used in Canada, and our only study site in the case control study was Ontario. So this is really a non-pooled single site study, and there was no increased risk of narcolepsy in either children or adults following Aripandrix. Fosetria was a two-stage, that's the MF59 adjuvanted vaccine, is a two-stage random effects meta-analysis of data from Taiwan, Argentina, the Netherlands, and Valencia and Catalonia, Spain. And for Fosetria, there was no increased risk of narcolepsy following MF59 adjuvanted vaccines in children or adults. And then for Pandemrix, our case control study data came from Valencia, Spain, and there was no increased risk in adults. I'm going to cover now some results from a case coverage study in the Netherlands. So in the Netherlands, cases born from 2004 through 2009 were analyzed using a case coverage design. So Pandemrix exposure in cases was obtained through a national database, and exposure prevalence was then obtained in the population for children born in the same year by calendar week and year of birth. This case coverage analysis was a post hoc off-protocol analysis in children in the Netherlands. The design allowed investigators to include information from the Netherlands where individual exposure data was not available. And in this analysis, there was no increased risk for narcolepsy following Pandemrix in children. So in conclusion, the incidence rate study data did not show a rise in the rate of narcolepsy following vaccination, except in one signaling country included, that was Sweden, which used Pandemrix. The case control analyses for AS03 adjuvanted vaccines, which are Aripandrix and Pandemrix, did not show evidence of an increased risk of narcolepsy, though the data were limited for Pandemrix. The case coverage analysis for Pandemrix in children in the Netherlands did not show evidence of an increased risk of narcolepsy, but the number of exposed cases was small. And finally, the case control analysis for MF59 adjuvanted vaccine did not show evidence of an increased risk of narcolepsy. I'd like to thank all the investigators involved in this study and be happy to answer questions.
And we'd like to thank you for that very nice presentation. Questions? Yes, Dr. Moore.
Thank you, Tom. A question, you mentioned at the early part of the presentation that the HLA type associated with narcolepsy varies a lot in populations, and I know it's unusually prevalent in Scandinavia compared to other parts of the world, but only one Scandinavian country was involved, and they did show a signal with the Pandemrix. How did the SOMNIA study address the prevalence of the HLA type in question that varies so much from population to population when addressing the question about narcolepsy?
I'll say in the European studies, there were several studies in the Scandinavian countries, in Finland and Sweden and Norway, I believe. So there were studies looking at, and those studies did show an increased risk. So here's a table of some HLA frequency, and we really were not able to incorporate this into the study. Although you can see that in the countries that we did look at, the HLA prevalence is anywhere from 15% to 25% of the population. It appears to be quite low in Taiwan, but this HLA is actually quite common, and that's probably in the range for what we would see, around 25% or so, maybe a little higher in some of those Scandinavian countries as well. So I don't know if that really answered your question, but it didn't really factor into our analysis.
Yes, Dr. Atmar.
So if a shortened lag time was a possible explanation for increased public awareness, then you might expect that with continued surveillance that the rates of diagnosis might actually go down because all those cases were diagnosed earlier. Has something like that been observed?
So you can imagine that this trend might continue down. So you're right. If what we're really seeing is detection bias, if the longer you extend the observation period, if the incidence isn't actually changing, you may see this temporary increase in incidence, followed by dropping below the baseline, then maybe returning to baseline. So I think that's work that we need to do to further analyze the incidence trends, looking at more follow-up time.
Other questions? Okay, I think we'll move on to Dr. Sylvester. Thank you.
Good morning. My name is Greg Sylvester, and I'm the head of medical affairs for Securus. Today I will present the phase 3 results for our adjuvanted quadrivalent influenza vaccine in young children ages 6 months up to 72 months. Here is the outline of my presentation. I will briefly discuss the disease burden of influenza amongst young children, then describe the composition and the mechanism of action for our adjuvant, and then present the study as listed here. I will say that when we get to the immunogenicity, that's only a subset of the entire population that we studied in this phase 3 trial. Influenza and flu-related complications pose a public health threat to young children, especially those under 2 years of age. Here's a slide showing the percentage of children hospitalized with laboratory-confirmed influenza presenting with an acute respiratory tract infection or fever. Influenza is an important cause of respiratory illness in children, and here, depending on the age, more than 20% of those hospitalized with acute respiratory tract infections is caused by flu. We also know that traditional influenza vaccines have been less effective in children, and thus the need for more improved vaccines in this age group. Therefore, Securus added an adjuvant to our quadrivalent influenza vaccine to improve the immune response in children. MF59 is an oil and water emulsion composed of squalene and polysorbate 80. Squalene is a biodegradable and biocompatible oil found in plants and animals. It is an intermediate metabolite in the synthesis of cholesterol. Humans synthesize it in the liver, and we also ingest it in various dietary sources. Polysorbate is a non-ionic surfactant and emulsifier, forming a homogeneous solution. We believe that MF59 enhances the immune system in several important ways. On the top left-hand side, it recruits macrophages to the injection site. It differentiates and recruits monocytes and neutrophils into antigen-presenting cells and increases their migration of these cells into lymph nodes. Where T cells and B cells activation expands the B cell repertoire, creating higher antibody levels, broader antibody coverage, and longer antibody responses. Fluad, which is the trade name, is Seqirus' adjuvanted influenza vaccine, and it has been licensed elsewhere for the last 20 years. It was first licensed in 1997 in Europe for adults over 65, focusing on those that have waning immune systems or immunosenescence. It's been licensed in Canada for older adults as well as children 6 to 24 years of age. And Fluad, as Dr. Walter pointed out, is licensed in the United States for 65 and above in 2016. Just to point out that both the United Kingdom and Australia have added Fluad to this year's flu seasons for enhanced protection. Here are the phase 3 results in children 6 months up to 72 months of age. We performed a multi-center randomized controlled double-blinded phase 3 trial that evaluated the safety, the efficacy, and the immunogenicity of pediatric Fluad compared with a U.S. licensed influenza vaccine in the age group that I've described. Now, you can see that we looked at safety for the entire surveillance or through the entire study. We did active surveillance, which meant that we were actually calling the parents during 6 months after they received the vaccine or to the end of the season. If they met the definition of influenza-like illness, which is written up there, then they were brought in and we did a laboratory-confirmed influenza test. We did PCR assay. There's a small, you can see that there's almost 11,000. It's 10,644. They're split equally, nearly 5,300 in the AQIV arm, and then 5,193 in the TIV or QIV. The reason that we started with the trivalent is that was the only licensed product in that age group at that time of the year when we were doing the study. The following year, it's a 2-season study, QIV was licensed, so we moved to QIV. And as I've pointed out, about a third of the children participated in the immunogenicity study. Here are the baseline demographics. As you can see, that the mean age is slightly over 3 years. Children enrolled in the study received either 1 or 2 doses, depending on their previous influenza vaccination history by parent and their age. If a parent stated that the child had not received a previous influenza vaccine, they were given 0.25 ml at day 1 and then returned within 30 days for a second dose. And if the parents had stated that the older child had already received a previous vaccine, would no longer be naive, then they would receive a 0.5 dose. And you can see that it's matched male versus female. Now, here are the baseline characteristics of the study. And as I've pointed out, the naive and non-naive was determined by parents, not by testing their blood. Season 1, you can see, enrolled less than 15% of the enrollees. It turns out that there are only 10 cases in that season. So 98% or higher actually occurred in the second season, where we enrolled 85% and higher. You can see that this really boils down to a 1-season study. What I want to point out is that in season 1, the vaccine actually matched fairly well to the predominant circulating strains that were out in the environment. But in season 2, 2014, 2015, if you look at influenza A, H3N2, all influenza vaccines had H3N2 Texas, but in fact the predominant circulating strain was H3N2 Hong Kong. Here are the study results, the PCR confirmed influenza. And this is for 6 months to 72 months. And if you look at the top row for any strain and number of cases, you can see that the AQIV, or Fluad, worked as well as the U.S. licensed competitor for that entire age range. That actually was our primary endpoint, and that vaccine efficacy missed the agreed-upon criteria set by the FDA and the company for success. And as you can see, that it's predominantly driven by the H3N2 strain, where of those 500 cases, 400 of them come from that H3N2 group. When we look at a younger age group, 6 months to 24 months, we actually see that there is a benefit with the adjuvanted product, where there were 55 cases compared to 79, or a vaccine effectiveness that's 30% better than the comparator. Once again, it was driven by the H3N2, where there were 44 cases compared to 66, and again, above a third, was a third better in the relative vaccine efficacy compared to the U.S. licensed product. We did do a subset of immunogenicity, and we looked at both geometric mean titers and geometric mean titer ratios, and the entire age range, 6 months to 72 months, as well as the two age ranges that are shown here on the slide, showed superior immunogenicity both by GMTs and the GMT ratios. We also looked at seroconversion, and subjects receiving the AQIV also demonstrated superior seroconversion for the entire age range, as well as the two age ranges that I have separated here on this slide. Here is the safety data. We solicited local adverse event reporting for the first 7 days after any vaccination. So if the child received 2, we would actually check it twice during that time. If they received 1, it would just be for that first 7 days. And as you can see, the AQIV group has a slightly higher local adverse event compared to the comparator group. But please note that there are very few severe local adverse events reported. We also looked at systemic adverse events, and you can see that irritability, sleeplessness, change in eating habits, and diarrhea were 20%. Those met 20% of the enrollees for the AQIV showed that they had one of those systemic adverse events. What most people have been asking us about is our fever rates. So here are the fever rates reported in the study. And so you can see that in the younger group, 20% of the Fluad group had noted fever compared to the 14% comparator. And across the entire age group, it was 19 compared to 9. Once again, you can see that the vast majority of the fever rates were less than 39 degrees Celsius. Now, we did look at febrile seizures, and there were 2 subjects in the adjuvanted group that had a febrile seizure, and 1 in the non-adjuvanted group. But as we know, and when I presented this data to the work group, as well as to the American Academy of Pediatrics Committee on Infectious Diseases, they really wanted to know about co-administration. So we went back and looked, and there are, as I've shown you, more than 10,500 children, but only 55, if you look at the N on the far right-hand side, 26 and 29, that actually may have received 2 vaccines within a 7-day window. So, other pediatric vaccines. So in fact, I would suggest that the numbers are just too small to make any type of meaningful conclusion from this slide. Clearly showing that there's very few fever but it's not necessarily the same day or different arms when they were receiving the vaccine. But I thought that since you all had asked, we wanted to make sure you saw it. In the two age groups listed on this slide, the proportion of children with any unsolicited adverse events were similar for AQIV and the comparative vaccine groups. And the same pattern was also observed with serious adverse events, new onset chronic diseases, and the adverse events of special interest. And we'll also say that of the new onset chronic disease as well as the special interest, we did not see any clustering, although we have followed those children closely. So in conclusion, we saw an increased incidence of local and systemic reactogenicity after vaccination with our AQIV vaccine. This is consistent with our past pediatric ATIV trials. The majority of local and systemic adverse events occurred within the first 3 days, were mild to moderate, and were only lasting up until 2 to 3 days. There was an increased incidence of fever compared to the comparator vaccine, and as I pointed out, there are 2 febrile seizures in the AQIV group and 1 in the comparator group. As I mentioned, the comparable incidence of the unsolicited AEs, whether they were of special interest or chronic disease, were similar. Efficacy and immunogenicity, when you look at that larger group, the 6 to 72 months, the vaccine efficacy for AQIV was comparable to the licensed U.S. comparator that we used with PCR-confirmed influenza. The AQIV elicited a superior immune response as reflected by the GMTs, the GMT ratios, and the serum conversions relative to the comparator vaccine in all 4 strains. On the efficacy and immunogenicity in that younger age group, we, in the 6 up to 24 months of age, the AQIV actually had significantly greater efficacy as demonstrated through PCR confirmed influenza. And again, looking at the immunogenicity, the AQIV elicited a superior immune response as reflected by the GMTs, the GMT ratios, as well as the serum conversion for all 4 strains. And with that, I thank you.
Thank you. Questions for Dr. Sylvester? Dr. Szilagyi.
Hi, thank you very much. Could you remind us what the exclusion criteria were for the RCT? Specifically, were prior seizures or febrile seizures one of them?
Yeah, so if they had a diagnosis of a neurologic seizure or epilepsy, they were excluded. Most of them, none of them had febrile seizures coming into it, because we do know there's an increased risk of febrile seizures after the first one.
Dr. Belongia?
Thank you. You noted the superior immunogenicity against the 4 vaccine strains. Now, were those HI titers against egg-adapted vaccine viruses? And if so, have you actually looked at titers against cell-grown viruses?
Yeah, that's a good question. So yes, they're actually against the assays. The PCR that we used was actually similar to what was in our vaccine. So we have not looked at them compared to a cell-based at this point in time. Something that we should do and can do, but we don't have those results.
Dr. Hunter?
Getting back to numbers needed to vaccinate, if you go to your slide on the 6 to 24-year-olds, Fluad versus the IIV 3 and 4, I'm getting a number needed to vaccinate of 60 in order to prevent, relatively speaking, one case of lab-detected influenza in that age group. So basically, you have to have 60 60 kids vaccinated. Does that sound about right to you?
Yeah, I think that your numbers are accurate. I think, yes, I don't know what more to say.
Thanks.
Dr. Walter.
Yes. Are there any plans for future studies to look at co-administration with other vaccines to look at fever rates in particular?
Yeah, so I will say that we do have a phase 4 trial that's going on in Canada with Professor Mark Loeb from McMaster, and this is his third year. And but in fairness, what we're doing in that study is it's typically done during a vaccine day when children come in a religious community, a Heterite community. So there may be some difficulty in finding that. As you pointed out when you introduced this section, this is not a licensed product in this age range. And we're still in negotiations with the FDA. I am assuming that if the FDA moves in the direction that we would hope they would move, that one of the post-marketing commitments would be looking at that.
Yes, Dr. Belanja.
The safety data was very helpful and interesting. One of the, I guess, concerns, particularly in children with adjuvanted vaccines, is the fact that if you start at age 6 months or 1 year, this child's going to get an adjuvanted vaccine potentially every year for a long time. And so are there any plans or is there any information in terms of the effects of being repeatedly vaccinated with an adjuvanted vaccine?
Yes, and so there are two things that from the first year to the second year in this study, there were 600 children that received a second vaccine. So they could have had two in the first year and then one in the third year, or they could have had one in the first year and one in the second. In the second year, we followed an additional 1,600 children and actually did a crossover. If they got a QIV, half of them 400 got a QIV for the second or just standard. And then in the same standard, they could have had a QIV or standard. And so we have, a little bit over 2,200 that are doing it. But my point earlier about the phase 4 trial in Canada, it does have a data monitoring oversight committee that actually is looking at adverse events and is there any potentiation with the adjuvant. And again, this is only 3 years of study. It concludes at the end of this year, but we have every intent to continue it for at least 3 more years so that we could have multiple years of data for the adjuvanted product.
I have one last question. You presented a slide with demographics on it. I wondered if you could comment on the diversity of the population of children in the study.
I can. So the first year that only enrolled the 15% was predominantly done in Europe and the U.S. So on the second year, we actually went to Asia and the Philippines, to be exact. About 45% of the study population is Asian. About 40% of the study population is Caucasian. About a little less than 15% is Black, and the remainder is other.
Other questions? Dr. Groskopf, I think you're up.
Good morning. Before starting, in addition to thanking our workgroup members who were listed on the slide that Dr. Walter presented earlier, and also thanking you all for your attention this morning, I want to thank the CDC attendees that regularly attend our calls and are extremely helpful in presenting data and answering questions for workgroup members, and really we couldn't get our work done without them. So what I want to do is just very briefly go over some considerations and ongoing discussions that we're likely to be having, and then I want to just go briefly over the 2018-19 recommendations draft and what's essentially new in that document or set of documents for those of you who have seen it. With regard to considerations, we had previews of all the information that you heard today, and I just want to briefly mention a couple of things. In general, I believe the thinking is that the 17-18 season safety data is reassuring. There was a bit of discussion regarding the quadrivalent adjuvanted vaccine data that was just presented, mainly centered around reactogenicity and the fact that we have at present very limited data on co-administration with other vaccines. You saw that the numbers in the study that we just saw were quite small for those that had any kind of concomitant or within the same week vaccination. I want to mention some ongoing discussions, some of which are related to what I just mentioned. We have, of course, have regular updates about vaccine efficacy and effectiveness presented to the work group and at these meetings. This continues, of course, to be a topic of major interest. And continuing with the theme of trying to make assessments of VE of certain types of vaccines versus others. As you saw with the FDA presentation, we have some ongoing discussions related to that. Of course, with regard to efficacy and effectiveness of LAIV4, which was recommended for use again for 18-19 as of the February meeting, egg-based versus non-egg-based vaccines, and vaccines for persons aged 65 years of age and older. And of course, we will continue to have surveillance, safety, and vaccine coverage updates. So next, I wanted to go over what is new and updated versus not in the 2018-19 recommendations. We generally have a vote on the core recommendation language each year, either in February or in June. We didn't do this in February, so we're bringing it up now. The ACIP members have been sent previously copies of the recommendations documents. We'll be doing it in the same format this year as last year, where the recommendations are sort of on their own with some limited explanatory references, and the bulk of the literature review has been put in another larger document. That was received well last year, so we decided to try it again this year. First, the core recommendation. The document reiterates the core recommendation that annual influenza vaccination is recommended for all persons aged 6 months and older who do not have contraindications. That remains the same. Next, a few pertinent updates to bring to your attention. These are updates that we generally don't have separate votes on. The first of which is the update on strain selection and the composition of the vaccine for 2018-19. U.S. influenza vaccine composition for 18-19 for trivalent vaccines will include a Michigan 45 2015-like virus. This is the same H1N1 PDM09-like virus that was present in the 17-18 vaccine. And then we have two that are updated for H3N2 and A Singapore INFIMH 160019 2016 H3N2-like virus. And for the B, for the trivalent, which will be a Victoria lineage virus, B Colorado 06 2017-like virus. The quadrivalent vaccines, which it appears will make up most of what will be available next year, will contain the above three, plus B Phuket 3073 2013-like virus, which is the Yamagata lineage virus. So next, some other updates. One, Flumist quadrivalent, or LAIV4. This is new language that was approved by ACIP at vote in 2018 and is summarized in the new recommendations document, and was also the subject of a recent MMWR policy note that was published on June 8th that just summarizes the data and the discussion. That's not the recommendations document. It was just meant to provide information about what the vote and the discussion in February was like. We also have updated VE We will have updated VE estimates for LAIV4 presented at this meeting as they become available. Contraindications and precautions to LAIV4 are in the document and remain the same as previously for LAIV4. There have been no changes there. And one thing I want to remind people of is that in the meeting prior to the meeting in June 2016, where it was recommended that LAIV not be used for the 16-17 season, the meeting immediately prior to that, there was a review of the use of LAIV4 in LAIV in persons with history of egg allergy. And use of LAIV for persons with a history of egg allergy was approved by ACIP at that meeting. So that is incorporated into the document for the 18-19 season. Essentially, individuals with a history of egg allergy may receive any licensed recommended age-appropriate vaccine. So lastly, as is typical when we update the guidance, we have some either new products or licensure changes, and we have one licensure change that's discussed in the guidance for the coming season. This is for Fluarix Quadrivalent, which was discussed at the last meeting. This is quadrivalent inactivated influenza vaccine, which is produced by GSK. This was licensed for children age 6 months or people age 6 months and older at the 0.5 ml dose in January 2018. These data have been presented to ACIP previously. This brings to a total now of 3 inactivated influenza vaccines that are licensed for this young age group of 6 through 35-month-olds. We have Fluarix Quadrivalent, which is also a quadrivalent inactivated at 0.5 ml dose, Flulival Quadrivalent, IIV4, 0.5 ml dose, and also Fluzone Quadrivalent, which is also a quadrivalent inactivated, but is given at least currently at a smaller dose of 0.25 ml. And there's discussion of the dose difference and the need to pay attention to administering the proper dose in the guidance. So those are the updates that are in the guidance, and with that, we have a proposal to reaffirm the seasonal influenza recommendations for the 2018-19 season, and I'd be happy to take any questions.
Thank you. Questions for Dr. Groskopf? Wonderful. Would someone like to make a motion? Oh, there's one back there. Sorry.
On the live attenuated influenza virus, I wonder if the AAP representative might want to say why they suggested as at last resort.
Thank you. So the AAP Committee on Infectious Diseases has also reviewed the same data that was reviewed by the ACIP, and our vote was to recommend LAIV, but to recommend it after recommending IIV as the first choice.
Thank you. Any further questions? Dr. Baker.
I would appreciate it if Dr. Campbell could clarify, because it sounds like you give IIV and then you give LAIV. So you're giving a preference, I assume?
Yes. So not to give both vaccinations, but to offer IIV as the first choice, and for those who do not want to take IIV, who would not get otherwise vaccinated, to offer them LAIV, if they're age appropriate and not contraindicated.
Thank you. Other questions? Could I have a motion to approve the recommendations?
So moved.
Thank you, Dr. Romero. And second?
Second.
Dr. Moore, thank you. Okay, so we are going to, is there any further discussion first? No? Okay. Any public comment?
So we did not get any registered public comment for specifically related to the influenza vote. If there is anyone who did not register, please let us know. Comment? I don't see anyone.
Okay. And do you want to instruct us about voting?
So pick up your voting things.
We'll call the question.
Everyone's channel should be on 41, but do not press 41. If you want to confirm your channel, you press the channel button. And then if you listed up here are the votes, and can you tell us when the voting's open? And the voting is open now, so you can vote using your electronic form. Your channels should all be on 41 without doing anything. 12. 14? 13.
13? One more? Did everyone vote? We're still looking into buying a new system. Still only 13. Do you want us to do it again? Okay. We're going to do it again because they are only getting 13. So if everyone could please vote again. Is the voting open? Sorry?
Just push it once. There's 14. We're waiting for 14 votes. And if this doesn't work, we'll go around the table. Okay, let's go around the table if that's okay.
Okay, we'll go around the table. Could we start with Dr. Hunter, please, and go to your right?
Hunter, yes.
Pellegrini, yes. You said left, right? Did you say go to the left?
No, I said go to the right.
Oh, I heard left.
We can't even do this. Okay, Dr. Hunter, start again, please.
Hunter, yes.
But it's not, there we go. Fry, yes.
Atmar, yes.
Lee, yes.
Belanger, recuse.
Moore, yes.
Bernstein, yes.
Walter, yes.
Riley, yes.
Stevens, yes.
Bennett, yes.
Romero, yes.
Szilagyi, yes.
Pellegrini, yes.
Thank you very much. So I believe the vote is 13 yes and 1 recusal. And with that, we approve the recommendations for 2018-19. Thank you very much.